Biliary System Part 2 Jaundice Definition Yellowish discoloration of the body tissues and fluids except for the brain, CSF, tears, saliva, and milk, which results from accumulation of the bilirubin in the blood. It becomes manifest when the serum bilirubin exceeds 2.5 mg per deciliter. The normal bilirubin level is from 0.2 to 0.7 mg percentage. Jaundice should be looked for in daylight. In people with dark skin, the sclera is normally yellowish, so look for yellow coloration on the mucous membrane of the mouth. Bilirubin metabolism divided into 5 stages: RBC's destruction, breakdown of hemoglobin, bilirubin conjugation, bilirubin excretion, and changes in intestine and reabsorption. RBC's destruction, the reticuloendothelial cells, particularly the bone marrow and the spleen, phagocytose old RBCs. Breakdown of the hemoglobin into globin, entering the amino acid pool. Heme transformed into iron and biliverdin. Biliverdin reduced to bilirubin, water insoluble, transported in plasma bound to albumin, forming unconjugated bilirubin. Bilirubin conjugation in the liver. Bilirubin plus glucuronic acid forms bilirubin diglucuronide. Conjugated bilirubin, which is water soluble, it's catalyzed by the bilirubin glucuronyl transferase enzyme. Bilirubin excretion. Conjugated bilirubin is excreted by the biliary passages to the intestine. Changes in intestine and reabsorption. Site of reabsorption in the terminal ileum and colon. Bacterial enzymes convert conjugated bilirubin to stercobilinogen, leading to oxidized to stercobilin, giving normal color of the stools. Up to 20% of stercobilinogen reabsorbed, and 90% of which is re-excreted by the liver, and the rest appear in urine as urobilinogen. Common causes of obstructive jaundice: common bile duct stone, common bile duct strictures following iatrogenic injury at cholecystectomy, and cancer of head of pancreas. Types and etiology: we have 3 types: hemolytic prehepatic jaundice, hepatocellular hepatic jaundice, obstructive post-hepatic jaundice. Hemolytic prehepatic jaundice due to excessive RBC's destruction in various types of hemolysis, characterized by elevated unconjugated bilirubin, increased stercobilinogen, fecal, and urobilinogen, urinary. Bile salts don't accumulate in the serum. Hepatocellular hepatic jaundice mechanism: liver dysfunction leads to inability to transform unconjugated to conjugated bilirubin, and so elevation of unconjugated bilirubin level in the blood occurs. Presence of intrahepatic cholestasis: some conjugated bilirubin is reabsorbed, and this elevates conjugated bilirubin level in the blood. Bile salts level may also rise. Causes: viral hepatitis, decompensated liver cirrhosis, bacterial infections as septicemia and pyemia, drugs as phenocybin compounds, certain diuretics, testosterone derivatives, oral contraceptives, oral antidiabetic agents, halothane, arsenicals. They injure the cellular excretion mechanism and leads to intrahepatic cholestasis. Obstructive post-hepatic jaundice due to obstruction somewhere in the biliary pathway, leading to conjugated bilirubin, which is reabsorbed to the blood and excreted in urine. Bile salts will accumulate in the blood, and fecal stercobilinogen and urinary urobilinogen levels are low. Causes: in the lumen of the bile ducts, there's calculi or parasites as Ascaris and Fasciola. In the wall of the bile ducts, congenital biliary atresia, inflammatory stricture as with sclerosing cholangitis or secondary to impacted stone for a long time. Traumatic stricture, iatrogenic following cholecystectomy or lithotomy or instrumental procedures of the common bile duct. Malignant strictures, and outside the bile ducts we have carcinoma of the head of the pancreas obstructing the lower part of the common bile duct. Mass of metastatic lymph nodes at the porta hepatis obstruct the hepatic ducts. Clinical picture: history. The age and sex of the patient may give a hint to the diagnosis, such as neonatal period, suspect, physiological jaundice, Rh incompatibility, neonatal hepatitis, congenital syphilis, congenital biliary atresia. In children, hemolytic anemia should be suspected, and in middle-aged females, calcular jaundice. In elderly males, malignant obstructive jaundice. Signs and symptoms of obstructive jaundice: jaundice, dark urine, clay-colored stools, and pruritus. Ascites may be present in advanced cirrhosis or metastatic malignant lesions. Jaundice is easily recognizable when the conjugated bilirubin concentration in the serum reaches 2 to 3 mg per 100 milliliter, or the unconjugated bilirubin level is from 3 to 4 mg per 100 milliliters. History of drug intake, recent injections, and blood transfusion. Color of urine and stools. For the hemolytic anemia, normal urine, dark stool. Obstructive and hepatocellular jaundice, dark urine and pale stool. Pruritus is absent in hemolytic anemia. Recurrent attacks of hemolytic crisis in hemolytic jaundice. The depths of the jaundice: mild in hemolytic and severe in hepatocellular and obstructive. Course of jaundice: fluctuant in calcular, progressive in malignant jaundice. There's pain. The hemolytic pain there's abdominal pain during hemolytic crisis, calcular obstructive jaundice, upper abdominal pain. Malignant obstructive jaundice is painless but may be accompanied by dull aching epigastric pain referred to the back. Examination: general, pallor, pyrexia, degree of jaundice, cachexia, bleeding tendency, lower limb edemas, stigmata of liver insufficiency, and Burkow's lymph nodes. Abdominal examination: in hemolytic anemia, hepatomegaly, splenomegaly. In calcular obstructive jaundice, negative abdominal examination. In malignant obstructive jaundice, the liver and gallbladder are commonly palpable. And to differentiate hepatocellular from the obstructive jaundice, give course of IV vitamin K for a few days. In obstructive jaundice, the prothrombin parameters will improve, while in hepatocellular there is no improvement. Investigations divided into laboratory and imaging. Imaging, we have MRCP, ERCP, PTC, endoscopic ultrasound, but the first investigation is the abdominal ultrasound. In obstructive jaundice, it shows dilatation of the intrahepatic biliary radicals. CT scan in patients suspected of having abdominal malignancy as carcinoma of the head of the pancreas. It shows site and extent of the tumor, invasion of the adjacent structures, metastatic lymph nodes, and finally liver deposits. ERCP used in obstructive jaundice with lesions involving lower end of the common bile duct as ampullary carcinoma, while the PTC used in obstructive jaundice with lesion involving upper end of the common bile duct as postoperative stricture or carcinoma of the hepatic ducts. For the laboratory, blood picture. In hemolytic jaundice, there's anemia and special tests to detect various types. Serum bilirubin in hemolytic, increased unconjugated; in obstructive, increased conjugated; and in hepatocellular jaundice, both types are increased. SGOT and SGIPT or transaminases. In hemolytic jaundice, there's a normal level of transaminases, while in obstructive jaundice, in early stages, the level is normal, but with prolonged obstruction, enzymes are elevated due to parenchymatous damage. In acute hepatitis, high level; in cirrhosis, moderate increase. Alkaline phosphatase in hemolytic jaundice, its normal level; in hepatocellular jaundice, maybe slight increase; and in obstructive jaundice, there's moderate increase, particularly in malignant obstruction. Prothrombin time and concentration, it's normal in hemolytic anemia, but we have prolonged prothrombin time and diminished prothrombin concentration in both hepatocellular and obstructive jaundice. Serum albumin is low in patients with cirrhosis or after prolonged malignant cachexia. Fecal stercobilinogen in hemolytic jaundice it's high, but in hepatocellular and obstructive jaundice it's low. The common bile duct stones pathology formation: in most cases, a stone in the gallbladder slopes through the cystic duct, reaching common bile duct. Primary stones in the common bile duct are rare and occur when there's prolonged stasis and infection. Brown pigment stones. Effect: no effect if the stone remains floating in the common bile duct without obstruction. Passage to the duodenum: a small stone less than 3 mm pass spontaneously through the sphincter of Oddi, leading to acute pancreatitis. Obstruction of the common bile duct leads to obstructive jaundice. Dilatation of the bile duct and intrahepatic biliary radicals. With prolonged obstruction, we have high pressure in the bile ducts. Bile secretion by the liver stops. Bile ducts become full of mucus, which is white bile. Complications are divided into 5 items: bleeding tendency, cholangitis, septicemia and hepatorenal failure, acute pancreatitis, and biliary cirrhosis. Biliary cirrhosis is uncommon in prolonged cases where the obstruction is intermittent or incomplete. Acute pancreatitis occurs if the stone impacts the lower part at the common channel of the pancreatic duct and the common bile duct. Bleeding tendency: bile salts fail to reach the bowel, so there is failure of absorption of fat-soluble vitamins, including vitamin K, leading to deficiency and the synthesis of the coagulation factors. Cholangitis due to infection by gram-negative bacilli. It leads to severe infection of the liver or even septicemia. Septicemia and hepatorenal failure. Absence of bile salts in the intestine allows absorption of bacterial endotoxins, and this leads to failure of filtration by Kupffer cells. Endotoxins cause renal vasoconstriction with glomerular and peritubular fibrin deposits, leading to renal failure followed by liver failure. Clinical picture: type of the patient, middle-aged females. Symptoms: asymptomatic, silent stones if there is no obstruction. Pain in the right hypochondrial and epigastric regions. Recurrent attacks of severe dull aching pain. Referred to the right scapular region or even to the back. Associated symptoms: nausea and vomiting. Jaundice. Course: slowly progressive and fluctuating. Degree: not reach a severe degree. Cause: stone impaction in the narrow distal part of the common bile duct. Fate: the stone whether slips into the duodenum or floats back to the dilated common bile duct, leading to relieving of the jaundice. We also have dark frothy urine, pale stool, and pruritus. Signs: itching marks, signs of bleeding tendency, purpura, and ecchymosis. The gallbladder is usually not palpable because of the chronic inflammation, which leads to fibrosis, thickening of the wall, and resisting pressure of the retained bile. Also, rise in pressure is low due to intermittent calcular obstruction. Bile duct stones are called choroidiculoides. Incidence: 15% of patients with calcular cholecystitis have stones in the common bile duct. Septicemia and hepatorenal failure are the usual causes of death in unrelieved obstruction. There is no relation between the size of the stone and the development of jaundice, because a tiny stone impacted in the ampulla may cause jaundice, while a large calculus in dilated common bile duct cannot cause obstruction. Charcot triad in cholangitis: it shows recurrent attacks of pain, jaundice, fever, and rigors. Reynolds pentad is Charcot triad plus altered mental status and shock. There's something called Courvoisier's law: a palpable distended gallbladder in a patient with obstructive jaundice. The cause of obstruction is not a stone, because malignant obstruction is the cause due to carcinoma of the head of the pancreas. Explanation is that malignancy leads to complete continuous obstruction, much higher rise in pressure, distension of a healthy thin-walled gallbladder, which is easily felt and large and palpable. Investigations: laboratory, blood picture. During an attack of cholangitis, there is polymorph nuclear leukocytosis. Liver function tests: bilirubin raised, mainly the direct. Usually bilirubin doesn't exceed 10 mg per deciliter and may fluctuate. Alkaline phosphatase is the most sensitive, with exclusion of other causes of raised alkaline phosphatase. Prothrombin time and concentration disturbed because of failure of absorption of vitamin K. Serum aminotransferases ALT and AST may show slight rise, especially if there's cholangitis. Gamma-glutamine transferase and 5-nucleotidase are both maximally elevated in obstructive jaundice. Differential diagnosis: hepatocellular jaundice due to viral hepatitis or drug toxicity. Malignant obstructive jaundice due to carcinoma of the head of the pancreas or cholangiocarcinoma of the bile ducts. Imaging: abdominal ultrasound, dilatation of the intrahepatic biliary radicals, diameter of the common bile duct is increased, normally it's from 4 to 7 millimeters. Chronically inflamed gallbladder with calculi points that the obstruction is due to calculi, but not conclusive evidence. Presence of stones in the common bile duct in a good number of cases. A mass in the head of pancreas may be detected. Abdominal CT demonstrates lesions of the pancreas or metastatic lymph nodes. ERCP detects lesions of the ampulla, and a biopsy can be taken. Visualized both the common bile ducts and pancreatic ducts. A stone will appear as a filling defect. Shouldn't be done during an attack of cholangitis, because the rise of pressure during injection of the contrast material leads to severe sepsis unless a therapeutic procedure to drain bile is planned. MRCP is good diagnostic but not therapeutic. Management aim is to relieve biliary obstruction by removal of the stones from the common bile duct. This is the first goal, and then remove the gallbladder, which is the source of the common bile duct calculi. Preoperative preparation: admission to the hospital for a few days for the preparation, correction of the coagulation abnormalities by injection of vitamin K1, prevention of the possibility of renal failure by adequate hydration by IV fluids, IV mannitol if urine output is not satisfactory, oral bile salts to diminish the liability to endotoxemia, and guard against liver cell failure by broad-spectrum antibiotics if there is evidence of cholangitis. Definitive treatment: the favored treatment is endoscopic extraction of the common bile duct calculi, followed by cholecystectomy by laparoscopy or open surgery. If ERCP is available, procedure: diathermy or electrocautery, do endoscopic sphincterotomy. The stone is removed by Dormia basket or a balloon caster. A large stone can be fragmented before removal, whether by mechanical or electrohydraulic or laser lithotripsy. Complications: bleeding in 2 to 9% of cases. This may be due to coagulation defects, so we should check prothrombin time and prothrombin concentration before the procedure and give vitamin K IV. Acute cholangitis in 1 to 3% of the cases. It may progress to septicemia and death, especially in cases with failed bile duct clearance after sphincterotomy. Pancreatitis: in 1 to 4% of the cases. If ERCP fails to clear the common bile duct of the stones, treatment is by operative exploration of the common bile duct, something called cholecystectomy, and removal of the stones together with the cholecystectomy. Procedure: the common bile duct is opened and the stones are extracted. T-tube is inserted in the common bile duct, which is closed around it. The long limb of the tube is brought outside the patient, help in the drainage of the bile in the early post-operative period. A T-tube cholangiogram can be performed after closure of the common bile duct to check the absence of filling defects, and this is called completion T-tube cholangiography. Cholecystectomy is then performed 10 days after surgery. A cholangiogram through a T-tube is performed, and if there are no residual stones and there's free flow of the contents to the duodenum, the tube is removed. In the absence of cholangitis, calcular obstructive jaundice is not an emergency. If the patient is debilitated with suppurative cholangitis, temporary relief of the biliary obstruction can be achieved by stent insertion at ERCP or percutaneous transhepatic biliary drainage, PTD, and definitive management postponed until the patient is fit for surgery. If endoscopic drainage fails, rapid surgery is mandatory to achieve biliary drainage. Strictures of the bile ducts: congenital biliary atresia, traumatic strictures, etiology: following cholecystectomy usually, or choledicculithotomy less usual. It may be due to complete ligation of the common hepatic or the common bile duct, narrowing of the duct due to its inclusion in a ligature, or devitalization of the duct due to rough dissection or ischemia of the duct. Clinical picture presents by biliary fistula or jaundice following cholecystectomy. Investigations: PTC, ARCP, MRCP to localize the site of the stricture. Treatment: trial of dilatation and stenting may be tried. If this fails, operative correction performed. The remaining stump of the common hepatic duct, if present, or the left hepatic duct, is anastomosed to a Roux-en-Y loop of the jejunum. Sclerosing cholangitis: unknown etiology, pathology. The intra and extra hepatic ducts are involved, and they have multiple strictures separated by normal or dilated segments. Clinical picture at first presents by obstructive jaundice. If untreated, it leads to liver failure. Investigations: MRCP or ERCP showing multiple strictures with beaded appearance. Treatment: anastomosis of a dilated segment of the bile duct if present to a loop of the jejunum. If there is no available dilated segment suitable for anastomosis, candidates for liver transplantation. Neoplastic stricture, carcinoma of the bile ducts. Predisposing factors: calcular disease, choledochal cyst, parasitic infestation by clonorchiasis, primary sclerosing cholangitis, ulcerative colitis. Clinical picture: type of the patient, commonly elderly males. Symptoms: obstructive jaundice in 90% of the patients. Pain, cholangitis, and anorexia are less common symptoms. Signs: hepatomegaly, gallbladder will be collapsed if the tumor at the porta hepatis, such as Klatskin's tumor, this is an exception to the Courvoisier's law. Distended gallbladder wall if the tumor is below the insertion of the cystic duct into the common bile duct. In cases of obstructive jaundice, if the gallbladder is palpable, it's most probably non-calcular, malignant causes, with the exceptions of associated chronic cholecystitis, previous cholecystectomy, malignant obstruction above the cystic duct, Klatskin's tumor. Investigation: abdominal sonar, intrahepatic biliary dilatation. The common hepatic duct or the common bile duct will be dilated down to the site of the lesion. ERCP useful in low strictures. PTC showing intrahepatic biliary radicals, the proximal dilated portion of the common hepatic ducts in high lesions. And MRCP. Treatment: for low strictures, if operable, pancreaticoduodenectomy, Whipple operation; if inoperable, stenting. High strictures, if operable, excision with Roux-en-Y hepaticojejunostomy; if inoperable, stenting by ERCP or PTD, percutaneous transhepatic drainage. Carcinoma of the gallbladder, pathology: gallstones are present in more than 90% of the cases. Microscopic picture: squamous cell carcinoma, adenocarcinoma, or both. The spread direct of the liver and porta hepatis by lymphatics to hilar lymph nodes, and blood or venous to the liver. Clinical picture: type of the patient, more common in elderly females. Symptoms: usually diagnosed after pathological examination of the gallbladder, which was removed because of chronic calcular cholecystitis. Acute cholecystitis if the tumor obstructs the cystic duct. Obstructive jaundice if the bile duct is obstructed by a tumor or metastatic lymph nodes in the porta hepatis. Signs: mass in the right hypochondrium. Investigations: MRI, CT scan, and ultrasound to visualize gallbladder, liver, and lymphatic metastasis. Treatment: if the diagnosis is suspected during surgery, it should be confirmed by frozen section, and if positive, radical cholecystectomy is performed. This operation includes excision of the gallbladder, excision of the wedge of the underlying liver, segment 4 and 5, and clearance of lymph nodes overlying the bile duct. If the lesion is fairly advanced and inoperable, this is the usual case, internal stenting to relieve the jaundice, and the prognosis for this lesion is very poor, and this concludes the biliary system.